Thank you, Dr. Mukesh. Thanks for this opportunity to be a part of this lovely course, so well designed, running for so many years, so popular because it deals with the basic aspects which are most important and the most important subjects in oculoplastics which are required by a general ophthalmologist are dealt with. So I'll be speaking about an anophthalmic socket, the problems associated with it. And this is a problem which has traditionally been considered a difficult area, but with simple algorithmic thinking for evaluation and management plans, it is not such a difficult area with results which are very gratifying. So when we talk about a cosmetically and functionally acceptable anophthalmic socket, we look for an adequate epithelium-lined socket, eyelids of normal length, appearance and tone, and a satisfactory implant inside the eye, inside the orbit to create the volume, a well-fitted prosthesis, absence of volume loss. So as you see here, a prosthesis which looks very much like the natural prosthesis and has a good modality. So when we talk about the abnormalities, we broadly talk about these four groups. There may be a lag socket or what we call an inferior phonic shelving. There may be surface abnormalities where the mucosa is not as healthy as we would have liked it to be, where there is a volume loss rather than surface loss, or there are associated eyelid conditions such as drooping or interning or ectropion, and you can further elaborate on all these and make an algorithmic plan as you go along. And we will look at them one by one. So let's first look at what a lag socket or an inferior phonic shelving implies. So when we talk about sockets, we often talk about this classical term called post-enucleation socket syndrome, which essentially implies that if you have not put in an implant following an enucleation to replace the volume, or if you placed an implant which is too small, the gravity causes the contents to shift down and forward, resulting in the inferior phonics become shelved, not deep enough to retain a prosthesis. So this is added to by the bulk of the artificial eye that you put in, which also causes the laxity to increase, and as a result you get a malpositioning and often coming out of the prosthesis. So this is the kind of appearance you get where you have the ectropion and where you have the exposed inferior phonics and the prosthesis is tending to come out. And when you assess this, when you pull this, you see that there's enough surface. You can make a deep phonics, but it has become just shelved. So the surgical options include that we tighten the lower lid, as Dr. Anita was speaking about, or you can form inferior phonics by a closed method where you're not giving an incision by sutures, or you can combine it with an open method where you have given an incision on the lateral side, undermined conjunctiva so that you create a raw surface which can create an adhesion when you put in those sutures. So this is how you mark the position where the phonics needs to be past these sutures, which you need surgical needles, big needles, which will take a bite through the periorbita and the periosteum and will recreate this phonics. So this is the closed method. And in the open method, I would normally just give a lateral incision, undermine right here, right up to the tarsus here, right up to the inferior orbital rim here, so that I have that raw area. When we pass my sutures through this, they would cause an adhesion, and these sutures need to remain in for a couple of weeks, and they provide very satisfactory, gratifying results. Now let's look at the surface anomalies, which is the second group, and contracted socket is one of them with its various classifications and associated abnormalities such as granulations, implant exposure, papillary reaction discharge, and fibrous bands. So this is all that you need to look at. You need to particularly concentrate on the phonesis and particularly on the inferior fornix. You may have various kinds of surface problems. Let's first look at the associated problems like conjunctival cysts, which form at time, granulation tissues form like this cyst you can see here, or granulation tissue like this, which forms because of chronic irritation, or you may have a granuloma associated with an exposed implant, which may need to be tackled with removal and graft. You may have these kind of fibrous bands, and they all need to be tackled. If there are localized bands without too much surface problem, you can deal with them by various techniques such as Z-plasties, as we have done here, and caused this fibrous band to not dent our superior fornix. So this is what has been done, and combined with a lateral tarsus strip for tightening. Now let's look at the contracted socket part, which is one of the major problems. It's been graded mild, moderate, and severe, and we know various reasons. If there are surgical problems or if there have been preoperative scarring, those are the causes for early contraction, and late contraction occurs because of inflammations like meibomian gland disease, like implant that has not been placed or an implant that is irritating, and so on and so forth. So mild socket contractions can be tackled often by taking care of the lash entropy and modifying the prosthesis. But if there is a moderate contracted socket where inferior, superior, or both fornices show contraction, with inferior fornix being the more important one, with resultant poor motility, non-closure in ophthalmos, and so on, these may require various measures. And prosthetic modifications do sometimes help, but often you need a surgery for these. And the grafting is the one that has given the most satisfying results. I prefer the lip mucosa with significant excess and fornix formation at the same time. So this is how you work. You give an incision, usually in the center, unless there is a central eyeball or a central implant, and then you can do a good undermining up to the bony margin to create the area where the band will form, adhesion will form, and you take mucosa, take the mucosa and put it in. It should be adequate, and at the end you should put in your conformer or your volume expander so that the graft can remain in position, and it usually results in very gratifying results. And you get a good motility. Amniotic membrane graft has been suggested, but is possibly not such a good option, because it is, after all, only a substrate and not a substitute graft, and it would work for minor problems only. Severe contractures may be very difficult to tackle, especially post-radiotherapy ones, especially dry sockets with epidermis like this, where you can sometimes get away with split skin grafting like this, and where we have managed to give her some kind of a prosthesis, and she's undergone a couple of surgeries later to take care of the lateral canthus. Now, volume loss is the other major problem, and this is where you either need augmentation, or if there is a surface problem as well, then dermis fat graft is a good option. So a decreased orbital volume may occur because you placed a small implant, or atrophy, or gravity that we have spoken about. And here, when you have this is a dermis fat graft that you take from the lateral aspect of the hip in an area which is not dependent, which you don't need for sitting. You need to make sure that you take just the right volume of fat, and you use a good closure of this side and do a good closure here, and you can get very good results. Can be a good option in children where it's supposed to grow as well as the child grows. And associated eyelid conditions like ptosis and entropy and ectropy also need to be taken care of. So you assess them like any other ptosis, but very often you need you may need a levator tightening or even suspension. So, and ectropions we've already spoken about. The LTS procedure is often the first choice, but there are other options like replacing the prosthesis with a smaller prosthesis. Lash margin entropy can be taken care of by the standard procedures. So this is how you assess and manage. You need to do a good assessment to see whether it's just a shelving, whether there is a surface problem like granulation, implant exposure extrusion, surface losses, volume loss, eyelid problems. Implant related problems we'll be talking about in another course. We have another course on anophthalmic socket day after tomorrow. Or is it tomorrow? Tomorrow. We have another course on anophthalmic sockets tomorrow, and I would invite all those who are interested to come in there for a detailed description only of an ophthalmic socket. So with an appropriate evaluation, an algorithmic approach to assessment and planning and choice of procedures, most cases can be helped to achieve a reasonable cosmesis for a good psychological rehabilitation, and we know how important it is for a person to have an aesthetic appearance for his confidence, for his ability to face the world. Thank you very much, and thank you, Mukesh, again. Thank you.
As always, sir, lovely, comprehensive. Just wanted to ask you, patients have received EBRT, and they come with a very avascular and very badly contracted socket. So any suggestions for that?
Hello. Those are the tough ones because they tend to fibrose a lot. So it's best to maybe try the conservative measures where you can. If not, go ahead with the mucous membrane grafting unless it's grossly contracted and has become a slit. Then as I showed, you can use an epidermal graft, a dry socket. But otherwise, a mucous membrane graft can be used with ample precautions, maybe use of some mitomycin C in the post-operative period, and pray to God that fibrosis doesn't spoil all that you have done.
Thank you, sir. Like you have very rightly mentioned about the use of good amount of, like we take buccal mucosa in such situation because we need a larger chunk of mucous membrane. But another option is if you can have some pedicle flap along with the blood vessel. So in such situations, sir, I usually take a temporalis flap, and this can either be covered with the amniotic membrane. Along with it, now too I use PRF in all my procedures and also skin graft. Only thing that when the child undergoes a radiation, there is not only a contracture of the soft tissue, there is contracture of the bone also. So that bony component is very difficult to manage. So many a times you might have to do some surgery in the maxilla and try to rotate it so that you get a deeper socket, and then you fill with a temporalis flap. I've been doing this, and sir, on 4th, tomorrow, right? We have a course on retinoblastoma. So there will be showing in enucleated socket, how can we manage like those with bad contractures.
So as for the bony contracture, as Dr. Kasturi was pointing out, the most important is prevention. So when you have an enucleation at a younger age, you must replace volume. There were earlier questions about whether an implant is placed in a post-enucleation socket or not. But now with the availability of imaging techniques, there is no longer the risk of the tumor recurrence being masked by an implant. So an implant is invariably used so that the bony socket can grow. Because if you get a bony socket which is small, then the problem becomes much more difficult.
Thank you, sir. That was an excellent presentation.